Hello, and welcome to Transformed Minds, the podcast where we explore real-world intersections of mental health, addiction, and transformative care. I'm your host, Dr. Owusu, though many know me as Dr. O. Each episode, we take a very thoughtful, practical, and evidence-informed look at how we can improve psychiatric and addiction care, from clinical settings to community spaces. Today is a host RX, just me and you, and I'm so glad you're tuning in. If you're new here, here's the vibe. Host RX is just me and you, breaking down the research, sharing what actually matters for our work, me and you. Expert RX brings in brilliant minds from the field, clinicians, researchers, physician scientists, change makers, experts, policymakers, whatever kind of expert you are in this field, we bring you in to share your expertise based on literature. And we have lived RX. That's where the real life stories come in. Guests who have lived it, survived it, and are reshaping the system because of it. As long as you've experienced it, you have that lived experience, and you are core to Transformed Minds. This episode is grounded in the study Management of Xylazine Toxicity, Overdose Dependence, and Withdrawal, a systematic review by Owusu et al. This study offers the first comprehensive synthesis of human xylazine exposure, integrating findings from 34 studies spanning from 1957 to 2024. It brings forward critical knowledge on toxicity, withdrawal, and dependence of xylazine. Clinicians across emergency, psychiatric, and primary care settings must act with greater awareness to make sure we're giving our patients the best outcomes. So why does this study even matter? It's because xylazine is showing up more than we've ever seen in overdose cases across the U.S., especially among males between the ages of 19 to 45 with polysubstance use. So, risk factors that the study has found based on the cases that have presented is male, age 19 to 45, and polysubstance use. All right. The other thing is also, we know that naloxone, which is evidence-based proven to reverse opioid toxicity, does not reverse xylazine effects. And there's currently no FDA-approved antidote that can help with xylazine toxidrome. Despite the severity of clinical presentation, xylazine often goes undetected because toxicology that we do in our hospitals, our emergency rooms, our clinics does not include xylazine. It's not comprehensive and does not pick up certain drugs on the standardized drug screens. So this study proposed guidelines from xylazine management cases that is currently in the literature. It's put together all the results from that, critically analyzed and examined the current literature, and has provided a reference guide for clinicians, for physicians, allied professionals, anyone treating people who uses drugs such as xylazine, in this case xylazine, to manage promptly xylazine toxicity, withdrawal, and overdose symptoms to improve patient outcomes. The goal is to promptly manage these symptoms to improve outcomes. We want to decrease the amount of overdose deaths. We want to increase the sequelae that follows the toxidrome if we promptly act. And again, the true significance of this study scientifically is we're hoping that though there's no standardized treatment or antidote, this becomes an open conversation that would bring aid in ongoing research to address the gaps that we have currently. It would also, we hope it can be a subtle call to action. And I say subtle because it's very scientific and not a lot of policymakers are going to look at it. But I hope if you're listening to this episode, which is dissecting the studies and highlighting what is going on, that you can be a voice to advocate for policy changes that can bring better psychiatric and addiction care to persons who use drugs. So, let's talk a little bit about what the study is teaching us about what xylazine is and what we know about it, right? So, currently, what we know is that xylazine originally was developed as a veterinary sedative, right? Basically a house tranquilizer, or it was used to tranquilize animals. And it was also a muscle relaxant. And it's mostly used for animals, never in humans. It's not FDA approved for human use, but somehow it has found its way to illicit drugs. We know that it also acts on the central alpha-2 adrenergic receptor. It's an agonist at this receptor, meaning it works very similarly to clonidine. And what happens is it basically dampens the effects of the norepinephrine system. It depresses that central system, and it can cause symptoms such as bradycardia, respiratory depression, hypotension, sedation, where you cannot arouse the patient. We will talk a little bit more about that. Xylazine, it's known in the street as Tranq, Tranq dope, or zombie drug. And this is because it reflects the powerful sedative effects and association of necrotic skin ulcers that we see in persons who use xylazine. Users are often very unaware that they're taking xylazine because it may be a bad batch of drugs that they bought from the streets or they took from someone, and they do not even know that's what they're taking. It's typically mixed with fentanyl or heroin, and people don't know. So it comes in many different forms. It can be a liquid injectable, which we see in the veterinary world where they use for large animals. It can also, when it's in the drug and being used illicitly, become like an injectable, like IV intravenous or intramuscularly. It can be inhaled and snorted. It can be smoked when it's combined with other substances. It can also be orally ingested, which is it's not as common as the other forms that people use it in. The doses currently that we've seen ranges from 40 milligrams to about 4,300 milligrams. We don't know much about it, but what we do know is the fatal dose ranges between approximately around like 1,200 milligrams can be a very fatal dose in an adult. Often, unknowingly, it's co-ingested with fentanyl, as I've mentioned, and we've talked a little bit about what happens when you ingest it. Like I said, it dampens like the central nervous system. It's decreasing like your sympathetic outflow, and it's similar to clonidine, but it's stronger than clonidine in the way that it depresses that sympathetic outflow. And this is where it results in sedation, where you try to wake up a person, they don't wake up, their heart rate is very low, sometimes mostly in the 40s that these cases that we've reviewed have shown. Very like low blood pressures, patients come in hypotensive, respiratory depression, hypothermia, analgesia, all of these things, right? The one major difference is it causes prolonged CNS depression when compared to opioids like fentanyl that we sort of know a little bit more about. And when you use together with fentanyl, guess what? Because fentanyl already gives you CNS depression. Now you're using it with another depressant. Double whammy. You're going to have very, very, very extensive CNS depression, which is why not sometimes, all the time, we haven't seen where naloxone has reversed xylazine, right? So naloxone doesn't really work. And when used chronically, as mentioned, you start to see the skin ulcers, especially at the sites where Xylazine is being injected. If you're using it IV, you're using it intramuscularly, anywhere that you're injecting it, you start to see that. How would you know if someone comes in with Xylazine toxicity, or is withdrawn from Xylazine, or is dependent on Xylazine? Most of the time you would not know, because I have already mentioned before, most people that come in, the tests that we run on them, the urine drug screens, toxicologies, they're not comprehensive and they do not include Xylazine. So if someone comes in and you're like, oh, he has a urine cup, give me some urine, most likely you're not gonna see it in there, right? Unless it's a place that has specific Xylazine test strips in their emergency rooms or in their clinics, they can test to see if Xylazine is in there. So most of the time you're not going to know. But the other side of it is you can know if the person tells you, I took Xylazine. We've also spoken about sometimes most people don't know that they took it because they got the drug from the street. It was mixed. They didn't know it's an adulterant, right? So they didn't really know. So what is the typical presentation you're going to see for Xylazine toxicity? Mostly the person will present with altered mental status, where they don't, what do we mean by altered mental status? They're either sedated, they don't really remember who they are, they can tell you where they are, what they're doing, what day it is. Like, they don't know what's going on around them most of the time, but most people are going to be unresponsive. That's how they're mostly found, unresponsive in the street somewhere. The respiratory depression can show as shallow breathing. They're not breathing shallow breathing, mild to moderate bradycardia, very hypotensive. Like I've mentioned, most of the cases that we reviewed, it showed 80/60s blood pressures, bradycardia in the 40s. Another big thing that we're seeing would be the EKGs, right? That's another presentation where you would see the sinus bradycardia on an EKG. So you have to monitor the patient on the telemetry because there could be cardiac changes that you may also see. Vital signs, as I've mentioned, so if you see a systolic blood pressure less than 90, a heart rate below 60, mostly within the 40s, respiratory rate less than 10, someone with necrotic, wounds on extremities, start thinking, Xylazine. What do I do? Xylazine, right? Some of the distinguishing features, so we know in opioid overdose, you see someone with pinpoint pupils. So in Xylazine, the pupils may be pinpoint, but it's not as small in diameter as opioid overdose. And I mentioned this earlier, studies have shown you have to read or listen to something at least 6 to 7 times to retain 66% of it. So I'm saying it again, right? Longer sedation, even after you've given naloxone, compared to opioids. That's what you see in Xylazine. And the bradycardia is very notable compared to if it's in an opioid that you're seeing. Again, no antidote exists, so when you give the naloxone, it's not going to work. And we're going to talk a little bit about how to properly administer naloxone soon. Okay? The study also talked a little bit about dependence, because even though it's a new drug, people, it's a highly addictive substance. So people are using it constantly. You're going to have a physical dependence and you're going to start showing some withdrawal symptoms, right? So there are people that are going to come in that are not going to have that toxicity, toxidrome that we've just talked about. Some people can also present with withdrawal symptoms. But before that, let's talk about how you would manage someone if they came in with acute toxicity of Xylazine, right? What would you do? Someone walked into your emergency department. The study summarizes from about the 34 studies that is included in the systematic review. It shows that monitoring the patient is very vital. So supportive care, that which includes monitoring the patient. Another thing is your ABCs, right? When you do BLS training, ACLS training, PALS training, all of those things, you learn your ABCs. We're like airway, blood, circulation, right? So you need to make sure that the patient's airway is patent, the patient is breathing, the person's able to breathe, right? If they're not able to breathe, I will link in here the flow chart, and we'll talk extensively about what the guideline the studies actually recommended. But one of the things you do is you're going to have to secure the airway. If the airway is not patent and the patient is not able to breathe, they're not waking up, you have to secure the airway. Very important. You can check, we've mentioned respiratory rate less than 10, so you have to check vitals, including the pulse oximetry. Put it on the patient, check it. You have to put the patient on telemetry, so electrocardiogram, EKG. You have to look and see sinus bradycardia. Are there any other changes that I'm noting with this person, right? Especially if it's somebody that has polysubstance use, that probably use multiple different medications, and it's not just xylazine, it's not just fentanyl, there's cocaine, all of those things. You're going to start seeing very massive cardiac changes, and you need the EKG to monitor that. You have to do blood work, CBC, CMPs, because we're seeing in some of these patients, the study also shows acidosis can be going on. Some of them may come with hyperglycemia. So these are tests that you have to do the blood work, CBC, CMP, glucose, lactic acid, get an ABG, because you want to know, is this patient hypoxic or not, right? Do your urine drug screen. So if someone comes into the emergency department with acute toxicity, like we've explained, these are some of the initial things that you can do. Imaging is also important. Consider, get a chest x-ray to see if, there's any aspiration. If someone has all these wounds, look for a wound imaging, because you don't know. The person may have an infection, cellulitis, osteomyelitis. Patient can have, sepsis. So these are all things, and your labs will help you do that. Your vitals will help you identify if there's any emergent things that needs to be managed and treated immediately. So it's very important to monitor the person. And as mentioned, labs, acidosis, hypoglycemia. I believe there was one study that mentioned that hyperglycemia is also seen, elevated lactate, all of those things you can see. And then management, acute management, again, airway, supportive. If you need to intubate the person. Very important. IV fluids for hypotension. If the patient is hypotensive, IV fluids can help. Bradycardia. Some of the cases in the emergency room, in the hospitals, it shows that atropine helped. It helped increase the heart rate, especially with those that had heart rates less than 50 beats per minute. It did help with the symptoms. So atropine can be tested, can be used, but also know when you're using all of these, none of these are FDA approved antidotes to reverse xylazine toxicity. What you're doing is you're actually symptomatically treating the person, because we don't have an antidote. So all we're doing is treating the symptoms. If the patient is hypotensive, you give IV fluids. The patient is bradycardic. Atropine have been shown to help. We know majority of people are co-ingesting xylazine with opioids. So that's why we're giving naloxone, in case we know it doesn't reverse xylazine, but in case the patient also not only took fentanyl, they took heroin, they took all of that, you can reverse at least the effects of those opioids. So that's why we're given that, right? External warming, right? Hypothermia can happen. So if the patient is hypothermic, you check the temperature, they're hypothermic, give them some external warming. Wound care. If they come in, they have some wounds on them, clean them, do some debridement, cover them, refer to wound care. If surgery need to be called, podiatry, depending on where, the wound is, if it's very extensive, because some people will come in with very extensive necrotic tissue. You're going to have to help them care for that, right? So now that we've talked about acute toxicity and what are some of the important things we can do when we see people, let's talk about withdrawal and dependence, right? So with withdrawal, The cases are showing onset about 6 to 12 hours after use. And it can last up to about 2 weeks for some of the cases that have presented. And the symptoms that most people come in with: restlessness, we see agitation, anxiety, insomnia, tachycardia, chills, dysphoria. And as you can see, this is very different from toxicity, where the person is bradycardic, the person is somnolent, the patient is non-arousal. You can't, like, literally, patient is like, you need to probably intubate this person, compared to the withdrawal, where they're agitated, they're anxious, they're restless, they can't sit still, heart rate is higher, they can't sleep. That's a different symptomatology than someone that is coming in with toxicity. So it's important to be able to identify the two. And if you know, like in most of the substance use presentations, some of these symptoms can overlap. They can even overlap with some psychiatric illnesses, right? So you have to be very careful and know what you're doing and promptly managing, which is why systematic reviews like these are important to help us. So management for withdrawal, clonidine, kind of similar to opioids. Clonidine is a mainstay. It's been effective. So you use clonidine. Most of it, the cases between 0.1 to 0.2 milligrams every like 6 to 8 hours, and try to taper that. Lofexidine is also another alternative. Benzos for very severe cases. We have to be very careful because benzos is also a CNS depressant. So you have to really be careful. If someone has a comorbid opioid use disorder, buprenorphine, for that overlap, get in care, consult, right? So specialty care. So consult, call if you don't have an addiction specialist. Try to see if you can use like a collaborative care model. Is there someone in the area? Is there an addiction medicine specialist? Is there a psychiatrist that may know a little bit more to at least get you started and educate you, right, on things like that? The Opioid Response Network is a good resource to use that can link you to an expert. They also have trainings and videos on there for you that you can watch and help you kind of learn more about a lot of these things. So one thing that the study looked at that was amazing, and I thought it was very important to sort of not just comprehensively summarize these studies, but also analyze critically and look at what are some of the gaps that we're seeing and how can we best fix these gaps? How can we best mitigate these gaps, right? For me as a clinician who participate or partake in clinical research, most of the time it's important for me to do a gap analysis, especially in a critical problem like overdose deaths, where we're seeing a lot of xylazine and adulteration with fentanyl, right? So look at the current state. What is going on now? Where do we want to be? And what are the gaps? What are the actions that we can take to get to our desired state? So in this study, there is a gap analysis chart that shows the current state where we are. We're seeing all these increase in overdose death where xylazine is involved. We're seeing a lot of xylazine hospital visits, right? So in the area where I work, xylazine is actually one of the top presenting substance overdose and substance implicated in the emergency room, right? A lot of people. And it's like a smaller town in the big state of it. But it has the highest, unfortunately, right? That in the borough, it has the highest in about 2-3 years ago. And we still see a lot of people come. And we know that it costs the taxpayer a lot of money. right? It's a very costly health expenditure, right? So that's where we currently are. And we're losing loved ones, we're losing productivity, like all these things. But where do we want to be, right? We want to be in a place where there's an increased awareness and knowledge about xylazine, how it works, how we can support people that use it, how we can effectively treat it, right? We want to be in a space, in a state where we know the safe and effective antidote and management for xylazine, whether it's toxicity, whether it's withdrawal, whether it's dependent. We want to be in a space where the effects on populations is decreasing, right? That detrimental, like the incidence, the prevalence of it is decreasing. We want to know more about the drug-to-drug interaction. Like, what happens when someone takes xylazine and they're taking benzos and they're taking cocaine all mixed together? Because sometimes that's where, like, it gets a little bit tricky for providers, because a person comes in and you have no idea what they've taken and you don't have the resources, right? One of the main gaps that we've spoken about is that we don't have access to like a comprehensive testing. Not every place, every emergency room, every clinic, every office, every community has easy access to test strips or testing for xylazine. Even like in the hospital that I work at, our drug screens does not pick up synthetic opioids, right? So like your fentanyls, your heroin, you're not gonna see them. You're not gonna see them on the UDS that we do. It's what we call a send out. So you have to send it out, and sometimes it takes a few like days, sometimes a week to come back. So if someone came in today and it's like overdosed or came in with toxicity, I have to wait a week to then figure out what they took to manage them. Just imagine the delay in treatment, right? So it's like we have these gaps. We have to figure out how we can get to a desired state where we have the resources, we have limited barriers to treatment, and we're giving people the safest and most effective treatment. So some of the actions that the study is proposing is, one, the guideline based on current literature, which is what we have put in the study. And we're proposing further research, right? We need more funding, more advocacy, more education, right? So I've been fortunate to be interested in a topic and learn more about it, but not every person knows a lot about it, right? So a project quality improvement project I recently did was not just xylazine, but just looking at harm reduction strategies and how, based on current literature, there's a lot of, one, stigma, but two, a lot of providers feel like we don't know a lot about it. Why should we provide it, right? That's one of the barriers. So I'm like, let me pick this barrier. Let me assess my space that I'm in, this hospital. Let's see where the providers in this hospital are, right? It's a QI project. So, the PDCA cycle, and see how we can fix that and give the people that we're caring for better care, better resources, better access, right? So being able to identify the gaps, propose or assess those gaps, propose what can work, implement those strategies, see what you need to change about it, and come back. And it's a little cycle. So that's what I have done in my area that I'm in. So actions that other people can do is replicate these things, right? Readily accessibility to standardized testing, I've already talked about that. Pharmacotherapy identification. So these are all actions that this study has noted that we can sort of start, take, and help. Okay. Baby, talking is a lot. Another thing that the study did really well at is the proposed guidelines. So there's a flow chart. If you just Google the study, management of xylazine toxicity, overdose, and withdrawal, a systematic review, Owusu et al., it'll come up. And what they've done, well, I'm part of them, is beautifully put together a flow chart, right, with recommended guidelines that shows, okay, when a person comes in, with overdose, xylazine overdose. What do? You look, okay, give naloxone. That's one of the first things that you do. They came in. Is it an overdose? Yes, no. Yes, there, all the symptoms that we talked about. You're looking at those symptoms, right? You did your clinical assessment, overdose, give naloxone. You gave the naloxone, you access for clinical signs, the patient recovers, right? You put the patient in a recovery position, supportive care, monitor the person, obtain a comprehensive history. If they recover, that means they're speaking to you, they can share something. If there is a family member, friend, someone you can get collateral information from, do that. Get urine drug screens. Try to get comprehensive, include xylazine, right? Even if it's a send out. Educate the person, educate the family, harm reduction strategies for wound care, right? But if the person comes in, they're not overdosed, but they're still showing signs of acute toxicity, right? Then you do your ABCs. You look at your airway, the breathing, and circulation. So you look at airway. Is it patent? If it's yes, assess for clinical signs, give supportive care, monitor continuously, right? A minimum of 48 hours. And the study proposed monitoring someone for a minimum of 48 hours because most of the studies, the case studies that were evaluated, the literature that were put together, most of the people, the average resolution time for those cases was 34 hours. And, we added a median. So there's a median time of about 25 to 25.5 hours in these cases. So we decided, okay, 34, let's make it 48 hours because, a lot of things can happen. Somebody may have recovered, but you don't know if they took multiple, if it's polysubstance overdose or toxicity. Some of these symptoms can emerge after they leave. So let's give them the 48 hours, the full 2 days, monitor them, see how they're doing, provide them with the resources, the appropriate care before you send them off and out, right? So that's why we're recommending that 48 hours. Also, you give naloxone and again, obtain a full comprehensive history because that's very important because sometimes you may be in an area where you don't have the testing, a lot of resources, but if you do a good history, try to get collateral information. The person themselves may tell you, yeah, I took xylazine, I took some cocaine, I may have taken some benzos, and that would help you. But if you don't do the history, you're not going to know, right? But if the patient is not breathing, the airway is not patent, then you have to secure the airway, which a lot of the cases that we looked, at least 10 of those cases, they intubated the person, right? Where they recommended intubation. And then you could put the person in a recovery position, ICU, right? So if you're intubating someone, then they're in a critical position. So I don't even have to tell you to call ICU or admit the person to ICU. That is a critical case. You've intubated the person. And some people may recover from there, some people may not. And then if it's, you do the breathing, right? Your ABCs, the breathing, you look at the respiration. Is it less than 12? Oxygen saturation. Is it less than 92 on room air? Chest. Is the person having like a symmetrical, chest rising or chest movement? Like all of these will give you signs of if the person is breathing, there's shallow breathing, they're breathing okay, or they need something else. If their oxygen saturation is low, again, we're doing symptomatic treatment, right? So you give them supplemental oxygen. If they need ventilation, if they need a valve bag mask, BiPAP, CPAP, whatever the appropriate supplemental breathing is, you provide that to the person and you continue to monitor them. If they need naloxone, you give them naloxone, right? And then you monitor the clinical signs. If they recover, yes, then you continue what you do during recovery. You continue to monitor. You obtain the history. If you weren't able to obtain it because the patient was not doing well in the beginning, now that they're awake, obtain it. Because you don't know if this person is going to come back but if you obtain that, you put the information is in the records. So if they happen to come back again next time, someone has that information, all right, to help them. Educate, educate, educate. Use your harm reduction strategies because the evidence shows harm reduction is saving lives. So make sure you're educating people. You're giving them the harm reduction strategies, wound care. Right. And then we come to circulation. So circulation, we've talked about how, people can be cyanotic, abnormal peripheral pulses, hemodynamic instability, hypotension, all of those things. Abnormal EKG can be as a result of poor circulation. So you look at all these clinical signs and then you treat them symptomatically, right? We've talked about this. Hypotension, you give them IV fluids. If they have electrolyte abnormalities, replenish them. If the person is hypotensive, hemodynamic instabilities, if you need to give them vasopressors, you give them. Because in some of the cases, they gave vasopressors and it helped the recovery of the patient. Consider calling either, the intensive critical unit, the CCU, whichever one is appropriate. Consider calling them based on how the person is presenting. Always and always, always, if you have psychiatry, addiction medicine, addiction psychiatry, get them on board. They are the experts, right? So they can help you in these situations. And then continue monitoring for side effects, unexpected interactions from, unexpected drug-to-drug interactions. Again, that's why we recommend at least monitoring these people for 48 hours because you don't know what else they may have taken, and you don't know what interactions may happen. For instance, again, if they've taken multiple CNS depressants, they may be awake now, but they may be unconscious the next time or the next moment. So make sure you're monitoring them well. Hyperglycemia, as I've mentioned, can be something that can occur as well. So monitor them. There are studies that show that they gave people IV insulin to help them. And then if this patient is well, the person is doing well, they're recovering, all of that, we go back to, educating them, giving them harm reduction strategies, referring them to the appropriate care, and making sure they get wound care. So that is the overdose. If someone comes in with overdose or toxicity. But if they come in, like I said, they're having the opposite symptoms, right? This guideline flowchart tells you if they come in with elevated heart rate, they're tachycardic, they're irritable, they're anxious, they complain of headaches. Even in some cases, it shows that electric-like sensations could be a sign of xylazine withdrawal. So if all of these things are being endorsed to you, then yes, the next thing can be, symptomatic treatment for the withdrawal symptoms. So clonidine, which you can use for the blood pressure and the anxiety. Dexmedetomidine has also been shown to be safe in poor airways. So if someone is not breathing well, shallow breathing, all of that, you can use that because it's been shown to be safe. And it would help with elevated blood pressure, heart rate, and is good for rapid sedation if you need to do that. And then tizanidine is another one that's similar to clonidine, but has very less cardiac effects, like elevated blood pressure and heart rate. And it is one of the medications that the cases that we reviewed showed that it can relieve electric sensations, bradycardia, and aches. So if you have someone that comes in withdrawing from xylazine, they're complaining of electric-like sensations, they're bradycardic, they're having body aches and all of those things, tizanidine can help relieve those symptoms. Guanfacine is another one that has been shown to be used as replacement therapy. Again, we're doing symptomatic treatment, right? So if they have headaches, all of those things, NSAIDs, ketorolac, acetaminophen, all of those things can be used. Gabapentin has been shown to help in some cases, and short-acting opioids can be used as pain relievers, right? Remeron, remember what I mentioned earlier, one of the signs is insomnia for the withdrawal symptoms, right? So if someone is coming in, they're unable to sleep and all of that, you could try Remeron, Seroquel, all of those things were also shown to help for sleep, right? Because we know Remeron helps with sleep, because it has a sedative effect and thiopine as well. But again, you have to be very careful when you're using all these medications for drug-to-drug interactions, especially if you don't know what the person took, right? And in the flowchart, other things that you have to really be mindful of that they highlight is when you give Clonidine for blood pressure and anxiety, you have to monitor for rebound hypertension, right? And very transient increases. So they can have, like, you give the Clonidine and you're like, oh, the person got better. And all of a sudden you see, whoop, blood pressure again. Don't go giving more and more and more. Reassess the person because it's likely rebound hypertension from the Clonidine that you use, right? And you have to also realize in adulteration, if someone used a benzo, cocaine, alcohol, and other opiates and all of that, you can use Clonidine. It's safe and it can help. So for the Dex medetomidine, it shows that you have to monitor as well for hypertension and bradycardia. So even though it's safe in poor airways, you have to make sure and keep an eye on the patient for, increase in high blood pressure and decrease in their heart rate. And it's been shown to be effective in children. That's what the cases showed, that it was effective in children, in opioids, co-use, in benzos, adulteration, due to that sedative effect, while yet maintaining a hemodynamic stability, right? So a lot of great information here, and always remember to put the person in recovery position, right? Okay, that was a lot. That was a lot. That was a lot. And I hope you got at least one thing from this management flowchart. So let's quickly walk through a case. So this is a 28-year-old man. He was brought in by EMS after being found unconscious outside an abandoned building. Heart rate is 42, blood pressure is 86/54, respiratory rate of 8, and saturated 91% on room air. Temperature is about 35 Celsius. Now, on exam, the patient is somnolent, but you're able to arouse the patient. Multiple necrotic ulcers on bilateral shins. His pupils are about 3 millimeters, but they're reactive. What do you do? What are some of the consideration you should have whilst triaging the patient? One of the first things is you should suspect polysubstance overdose, maybe like fentanyl and xylazine. Why? Because the patient is coming in with bradycardia. They're also coming in with respiratory depression. They have multiple ulcers, right? And it looks like they may be a little hypothermic. So it looks like it could be xylazine. But be aware that fentanyl mostly is being co-used with xylazine, right? There's that adulteration, so you have to suspect that. And then next thing you do from the guidelines that we just looked at, you have to initiate your ABCs, right? Airway, if it needs to be protected, because in this person came in unconscious, right? He's somnolent but arousal, but is he talking to you? Is the airway patent? That airway needs to be protected. Respiratory rate is less than 12. It's 8. So we have to start our oxygen. The patient is hypothermic, so you have to give them external warmings, right? So put some warm blankets on them. Because it's looking more like a xylazine case, but fentanyl is mostly seen with xylazine. You have to administer naloxone empirically, just to see, even if the patient is partially aroused, give them the naloxone, okay? Monitor the EKG, because sinus bradycardia, we've spoken about that, you have to monitor it. And if you're suspecting substance overdose, you may see different electrical changes and activity on there. So put this person on telemetry and look at them. IV fluids, because the patient's very hypotensive, right? Systolic blood pressure of less than 90. So you have to give those IV fluids. and improve the blood pressures. Workup. We talked about this. Most people can present with acidosis, hyperglycemia, all of those things, or hypoglycemia. So if they're overdose, toxicity versus if they're withdrawing. So you have to get your CBC, CMP, lactic acid, urine toxicology. Because this person has wounds, you have to make sure you're getting your wound culture first before you start any antibiotics, because you don't want to mess that culture up by treating it before, because if you treat it before, you're probably not going to see or know for sure what infection it is, right? Or what bacteria, what fungus, what virus, whatever it is that's causing that. The organism causing the infection, you wouldn't know if you treat it before you take the culture. So take the culture, then treat it. All right. And then disposition planning. This patient is likely intubated because they're not responding to the treatment. They're not arousal. Well, they're sort of aroused, but they're not really there. So call ICU, admit to ICU, even if it's for observation, consult psych, consult addiction. Consider clonidine if they start to withdraw. And if you're discharging them after, at least monitoring them for 48 hours, refer them for outpatient wound clinic for medication-assisted treatment programs. Give them resources, right? The person was found in an abandoned building. Guess the time that they were there, get social work on board, or case management on board. Find out, what resources do they need? Why are they even using? Do they need to go to, a substance use clinic, right? A MAP program, give the person the resources they need. Give them the resources they need. I'm going to stop there. Okay. So we've talked about a lot, but I want to summarize this. If you don't get anything out of this, this can apply for anyone. What to do when you see someone that may have overdose? What do you do? What to do during an overdose situation, right? The first thing is try to wake up the person. And you do so by appropriately shouting, shaking the person, give a sternal rub, right? So this is a sternal rub. Knuckle, chest, rub them. All right, that's a sternal rub. Basically giving them a painful stimuli to see if they wake up. So you could pinch right here. What is this? The nail bed of a finger, right? Painful stimuli to see if they're going to wake up. If they don't wake up, call 911 or administer naloxone. Whichever one is the easiest first of these two things. If calling 911 is easy, call that first. If giving naloxone is easy, call that first. Caveat. If you're given naloxone and it's fentanyl or the naloxone is going to work, when you give it and the patient responds, take a step back, because you don't, you're giving it to a stranger. Make sure you're not getting harmed or they're not getting harmed. So keep that in mind. Administer naloxone and call 911, right? If they're still not breathing, after you've done that, provide rescue breathing or reposition the airway, right? If you're uncomfortable giving the rescue breathing, it's okay to reposition the airway. Okay? If still unresponsive, you've waited 2 to 5 minutes and the person is still not responding, you can give another naloxone. Right? Naloxone takes at least 2 to 5 minutes to work, right? Average 2 minutes. So if you gave naloxone and it's 30 seconds, 1 minute, and the person is not up and you give another one, it's most likely not gonna matter, right? Because it takes at least 2 minutes to work. So wait 2 to 5 minutes. If the person is still not responding, give another naloxone dose. Once breathing resumes, you can place the person in a recovery position, right? That's putting the person on the side. The arm is out of the way. Their mouth, like they're able to, if they're throwing up, it's able to come out of their mouth. There's nothing covering their nose, right? And the mouth, right? So you want the airway to be open, right? And not blocked. So put the person in recovery position. I will put something. So if you look at the study that we looked at, there's actually a beautiful illustration done by one of the authors. Dr. Atodaria did a beautiful illustration of the recovery position. So take a look at that, how to put someone in a recovery position. Stay with the person for at least 3 hours. Remember what we've talked about. Monitoring is very important because you don't know if like other substances are involved. The person can go back into like a somnolent state. So you have to monitor the person. And if, fentanyl is involved, you have to monitor them for even longer. So just make sure you're calling 911 as well. So let's talk about how to administer naloxone, because I've told you to at least administer naloxone twice if the person doesn't wake up. So how do you administer the naloxone? So if you're someone that carries naloxone with you, and you can get this free of charge, I know they can ship it to your house. You can request them and then they can ship it to your house. Or you can pick them up from any like substance use clinics, all of that. Majority places supply that. I'm not going to say all because I don't live everywhere and I don't know how things work everywhere, but majority of places have them. At least in New York, I know you can get naloxone for free and easily too. So what you have to do is remove the nasal spray from the box, right? It comes in a nasal spray. Remove it from the box. Do not prime or test. Like, don't do any of that. Just take the medication out of the box. Hold with your thumb under the plunger. I should have actually, I have some at home, but it's in my medicine cabinet. I should have brought one out to do the test. But I'll put a link in this episode somewhere of a video of how to do it, because I'm telling you, but seeing it is actually probably better. I should have brought my kit here so I could have shown that, but I apologize. I'll put a video, take a look at the video of how to do it. So you remove the nasal spray from the box. Do not prime or test it. Like I said, you hold it with your thumb under the plunger and your 2 fingers on the nozzle, right? Under nozzle. Under plunger, 2 fingers on nozzle. Tilt the person's head back, right? And then insert it. You have to support the back of their neck too. And then insert it in one nostril until your fingers, these fingers touch the nose. So insert, fingers touch nose, right? And make sure it's going up, because you don't want to put it right at the edge here. You want to make sure it's up in the nostril. So you insert it there, your fingers touch it, press the plunger firmly, and deliver the full dose. Remove it, and like I said, it takes about 2 minutes for it to work. So wait at least 2 to 3 minutes. If the person does not respond, administer second dose in the opposite nostril. So if you did this the first time, use the other one. Perfect. Okay. Common error. I've said this. I'm going to say it again. This is 66% after you hear something 7 times, you retain 66%. So I'm saying it again. Giving a second dose too soon is a common error. So always wait 2 to 3 minutes to avoid worsening withdrawal symptoms, because you don't want to put someone into withdrawal. So wait at least 2 to 3 minutes before you give it again. So, clinical pearls. Suspect xylazine when naloxone yields only partial effect or no effect, and the person has bradycardia and has some ulcers present as well. Suspect the xylazine can be involved. Wounds are a diagnostic clue. So inspect all the extremities. They come in with overdose. Naloxone is not working. Look for wounds. That could be a diagnostic clue. Treat withdrawal early. Okay. Wound management, multidisciplinary. Take a look at the guidelines with all the medication that we've talked about that can help with withdrawal, atropine, that can help with the bradycardia, all the symptomatic treatment that these cases have shown had worked for people. Take a look at them. Okay. Document and report cases to improve recognition and surveillance. But the most important thing, you are a clinician. You are a physician. Use your clinical judgment. Use your clinical judgment. It's imperative, right? Educate yourself, learn more, and use your clinical judgment. So, thank you all for listening to us. Well, to me. Thank you for listening, right? What I would say, my final thoughts on all of this, on this study, is what we've learned is that xylazine is adding a complexity and severity to the already deadly opioid epidemic that we're experiencing. And we have this review that underscores the need for frontline awareness, education, supportive treatment, and system-level preparedness. Like, everyone needs to be prepared. For clinical checklists and decision tools, please take a look at the guidelines in the systematic review. Share with your team, educate on harm reduction. And until next time, stay ready, stay aware, and stay grounded. Thank you for coming to the Transformed Minds. I appreciate you. Bye.